understand what a true dislocation is. We know what a dislocatable
बहुत
knee
बढ़िया है
is. That's a knee that may look from the X-ray relatively normal when it comes into casualty, but
ये रहने ना बीच वाला थोड़ा
clearly suggests that
ये लो
something
सर
serious.
निकाल दें
We can define it according to whether both
नहीं निकाल दो
cruciate ligaments are
निकाल
injured
दो
or whether
हाँ ये रहने
the
देते हैं
destruction of two or more
हाँ
of the major ligaments. There are a couple of classifications of
ACL वाला क्लीन कर लो
traditional
ACL वाली
classification
साइड
as outlined here, the commonest being the posterolateral rotary dislocation.
नौ की बना लूं
But there's an anatomical
नीबू
dislocation that is
नौ की टनल
divided into 5 categories. And even category 1, you'll see, is a serious injury because it must have at least one or two of the collateral ligaments that are ruptured together with one of the cruciate ligaments. The demographics of these injuries are that they are predominantly found in the male population. Most of the large series have a remarkably similar mean age of injury in the mid-30s, and the mechanism tends to be either sport or transport-related injuries or a fall. And occasionally all three may occur at the same time, although this is pretty rare. Those of you that have kept an eye to the news recently will need to know that this helicopter wasn't made by Western. I haven't taken any money to show this slide. Okay, what are the common injury patterns? There's one useful paper from New Zealand from 2003 that looked at 60 patients and looked specifically at the type of injury that was sustained. They found that 84% involved the ACL. Most of these were mid-substance, but 1 in 4 was a distal avulsion. 87% involved the posterior cruciate ligament, and half of these were mid-substance, but half were proximal avulsions. And these avulsions are important to recognize, as we'll see later. 44% involved the medial collateral ligament, and again the majority of these were avulsions. A small majority were mid-substance, and the majority of the avulsions were proximal. Lateral collateral involved in 62%, only 4 were mid-substance. And of the lateral injuries, including the posterolateral corner, distal avulsions tended to occur with a proximal, with an intact proximal part of the complex, and the proximal avulsions tended to have a distal attachment that was intact. And again, this is very important when we come to considering how to manage these patients. Well, what are the associated injuries? Vascular injuries, the popliteal arteries, obviously at risk, predominantly because of its tethering proximally.
वो पीछे क्लीन कर लो पोस्टो मिडल एरिया ना ये थोड़ा क्लीन कर लो
depending on which series you look at. My experience certainly is that the incidence is at the lower rather than higher end. There's a high association with PCL injury, and the question that's often asked here is whether there's a role for routine arteriography, and there will be proponents both for and against this. But the literature tells us that there tends to be a low yield if the clinical vascular examination is normal, and with pulse asymmetry, we're looking at a group of patients there where demonstration of the vascular anatomy.
ठीक है पोस्टियर हॉर्न तक जा रहे हैं हम ये पोस्टियर हॉर्न है ना ये पोस्टियर हॉर्न ये आ गया रेस्ट से वो भी कर सकता हूँ थोड़ा दे दे रेस्ट
injuries associated with a varus strain or medial translation.
Flex करना will flex.
89% have been noted with having an association with posterolateral corner injury and with a distal biceps avulsion. So when you see this combination of injuries, think hard about whether
थोड़ा middle जा रहे हैं हम थोड़ा midline में जा सकते हैं
recovery with
ये
injury
कार्ड लेने तो
is 50%, which is an argument
चला गया middle line में चला
against early exploration in some cases.
ये देख
And the tibial nerve is rarely injured, but if it is injured, it's usually in combination with the peroneal nerve, and this represents part of what is the most serious injury complex within the knee and represents a limb-threatening injury combination. Bony
ये थोड़ा
injuries
काट लेते हैं ये वाला गंदा सा लग रहा है ये पता नहीं
recognized.
दिखेगा नहीं बाद में कुछ भरोसा नहीं
With ACL tears in 75 to 100% of cases.
कॉटरी
And also with distal injury,
लाइट थोड़ी कम कर दो
corner injury.
रोशनी थोड़ी कम करोगे
Reverse second,
नहीं ये
proximal
नहीं
tibial intercondylar eminence fractures.
लाइट सोर्स की
Recognized associated bony injuries. So the mechanism of injury tends to be
हाँ यहाँ से कम करना सर करना सर बस और कम करना
to have this type of injury with low velocity trauma, and I've
राकेश कहाँ है तुम्हारे साथ नहीं है राकेश
lateral corner
राकेश कहाँ है
injury and an ACL injury with
बाहर
just by
अभी है लिनवाटेक में ही है
pen from underneath his
यहाँ से डालना सर
ये ना. It tends to be as well. This is an important point to remember. A weak
हाँ ठीक है अब ठीक है हमने कर दी कम
nerve and vascular injury. So if you've got a low velocity trauma, that doesn't mean to say that you can't have a vascular injury. So what are the realistic goals with these patients? Well, if we look through the literature and what it tells us over the last 20 years or so, we can expect patients with that have been treated for to have a listen score of between about 80 and 90. The Tegner score tends to drop by 1 or 2 points, which means that this is a career-threatening injury for a high-level athlete. There tends frequently to be PCL laxity, and the injured knee rarely feels normal. So this raises the question of whether we can actually do better in terms of our outcomes. And we need to ask five questions, I think, if we're going to have that as an aspiration. We need to consider the role of early surgical management, the timing of early surgery, the extent of early surgery management, and whether or not there's a role for planned late surgical management. And then we also have to have an eye on rehabilitation. Treatment decisions. It's important to remember that there is no definitive paper or series of papers.
इंसिजन दे नहीं दे फिर कौन सा पोस्टरमल सेफ्टी दे दे वो भी दे देते हैं और ये भी दोनों चीजें दे देते हैं
identify patterns and trends, but there's a lot of conflicting evidence, and this is partly because of the outcome measures of which there are so many nowadays, and for which there's no uniformity in terms of how patient series are assessed. But I think the message we're getting is that we really need to assess patients according to their own subjective assessment. So we're looking, I think, for papers now that have like Q's scores that have got patient-reported outcome measures, and I think there's an argument for purely objective outcomes alone probably not having any role in the way that outcomes are publicised. So the role of early surgical management, well, we know that there are poor results from conservative management. I recall the day in some hospitals when I was training when a dislocated knee was put into a plaster cast, and it was the hope was that it would stiffen up sufficiently that they'd never get any instability symptoms. But I hope we've all moved on a long way from that. I think the diagnosis
हाँ ये वाला एरिया काट सकते
है ना थोड़ा और साफ हो mandatory. We can't plan
जाना यहाँ बड़ा डिफिकल्ट हो
without knowing what's injured.
जेग वैसे वहाँ तक जाएगी नहीं
and the EUA is mandatory in all cases. We need to ask ourselves.
सर ने ये पीछे है सर पोस्टर ये नहीं सर ये नहीं सर ये नहीं ये बस ये वाला ठीक सर ये वाला टिश्यू नहीं सर ये नहीं सर छोड़ दो रहने दो सर कुछ
कौन सा कह रहा है
नीचे जो थिक था ना ये वाला वाइट वाला कर सकते हो अगर जाते हैं हाँ
मैं तो ये सोच
नहीं सर ये नहीं है ये पोस्टर है ये नहीं जाना है छोड़ रहने दो रहने देते हैं सर
अच्छा नजर आ रहा है विजुअलाइजेशन अच्छा क्या आएगा बैक ऑफ द टिबिया पे पहुंचे हुए हैं इतना अच्छा when a patient presents, they're sent quickly to an expert who can deal with this difficult problem. इसका फुटप्रिंट मार्क कर दें role of early surgical management TCL का जिग दिखाना फुटप्रिंट मार्क कर देते हैं literature tell us Hana looked at 19 patients 8 पे करना है ना हाँ सर that underwent repair and reconstruction using allograft within 3 weeks of injury and 12 he compared those 19 patients with 12 who had late repair and reconstruction Now these are not matched patients.
थोड़ा सा और ऊपर रखना पड़ेगा क्योंकि एंट्रोलैटरल बंडल ऊपर है ना,
यहाँ पे कर दे
थोड़ा और ऊपर ये क्लीन करना, ऊपर वाला पार्ट ना, बंडल जो एंट्रोलैटरल बंडल का ऊपर है,
यहाँ रख लेते
हैं. Not particularly good bunch. The conclusions were that the patients that had early reconstruction and repair tended to fare better.
यहाँ पे रख दूंगा.
When taking that on board, you have to consider that
बोल भाई जोशी.
हाँ सर ठीक है.
Indications to early treatment.
हाँ नहीं बोलता.
ठीक है ठीक है.
Whether the injury is compound.
लाइट जब क्वार्टरी चलती तो आधे, अदरवाइज जब कम तो करा लिए.
Significant bony injury. The timing of surgery, I think, is critical. I think you've probably got a window of 2 or 3 weeks to operate on these patients and carry out any primary or early surgery. And if you miss that opportunity, you've got a much more difficult clinical problem to deal with. The extent of the early surgical management depends largely on your philosophy. I think most people would accept that you repair what is repairable. You then have to ask what should be augmented in terms of the repair. And going back to the slides that I showed earlier, where there was a high incidence frequently avulsions of cruciate, posterolateral corner ligaments, medial ligaments.
ये ऑडियो वीडियो वाले कर सकते हैं ऐसे काम.
That you might consider not to be repairable are repairable.
तो ऑडियो वीडियो वालों को वहाँ से
उधर का टर्निकेट डिफ्लेट हो गया.
Associated with a knee dislocation. Remember, the PCL is the most common ligament that's associated with a knee dislocation. 50% of those are amenable to early stabilization and or repair because they are an avulsion injury. My preference for augmentation is particularly for posterolateral corner and patella tendon ruptures that can be repaired if they're mixed.
वेबू को तो कोई प्रॉब्लम नहीं.
I think alone a mid-substance repair is insufficient. That then brings us on to the question of early repair with a late reconstruction or delayed reconstruction. And there are 3 papers I've picked out here that are small series, small case numbers, but I think this illustrates the point I'm trying to make, that there isn't a huge lot of very good quality, certainly in terms of numbers, papers in the literature. And these series demonstrated reasonable results, but with some significant complications. And one of the problems with these 3 series, which is frequently seen in any series of knee dislocations, is the rate of stiffness. And arthropfibrosis, which requires MUA or arthrolysis, is not uncommon. We look specifically at 4 series. We've got rates 4 out of 23, 4 out of 7. 2 out of 13 that have had significant stiffness and sufficient to warrant some form of surgical treatment.
Better आती है मुझे लगता है orientation थोड़ी.
So again, what about early repair and plan delayed reconstruction allows the
ट्रांसपोर्टल लोग आजकल देखना चाहते हैं ना चीजें.
to restore anatomy, and it allows early mobilization. It's possible that arthropfibrosis may be less of a risk, and it allows reconstruction of the ACL and or PCL when the knee is more normal.
डबल बंडल में ठीक लगता है.
Ask you to think about this philosophy in the same way as many people do in terms of treating the isolated acute ACL, where you let the knee regain some sort of normality, not operating on them within the first few days. And I think that's the method that certainly the majority of ACLs are managed in the UK, and I know in many other parts of the world. So it's not, we don't have to go far from that philosophy to accept that with a dislocated we may be able to manage these along those lines. And it's the other point to remember is with a planned delayed reconstruction, if you've got a primary repair of everything that's repairable, you may not need to do a late reconstruction, particularly in older patients that can function extremely well. I've looked at my last 20 patients that have had a year's follow-up, that have had a combined MCL and ACL. Now, this is a knee dislocation by any one definition, and I'm not suggesting that the results of this can be accurately used to draw conclusions about injury management. But nevertheless, I think there's some things that are useful that can be drawn from this. The patients had a mean age of 35, which again you'll see corresponds to the series that I discussed earlier. The majority were sporting injuries, and the majority of those were rugby. An early diagnosis was a combination of X-rays, MRI, these patients underwent primary.
कौन था मेल वॉइस थी फीमेल वॉइस थी
Then underwent rehabilitation with
आदमी बोल रहा था औरत बोल रही थी
moderately aggressive rehabilitation protocol with a view to undergoing ACL reconstruction. Now, not every patient had to go down that route. If they felt after a period of rehabilitation that they didn't want to, or they felt they didn't need to, they weren't forced into it. But 17 out of 20 did have ACL reconstruction, 12 of which were within the first 6 months. And these patients have been followed up with a minimum of a year. But this is, I have to tell you, this is an incomplete follow-up. But the summary results that we've got, out of the 17, we had 1 graft failure and 1 superficial wound infection. We had no loss of range of movement, no pivot shift, no functional instability, and no drop in the Tegner score. So these are relatively encouraging results. I think that certainly make me happy that this is a method of treating this
सर थोड़ा ऊपर की तरफ करना क्योंकि टनल थोड़ी ऊपर बनाएंगे यहाँ सुपीरियर बनाएंगे नॉच की तरफ
say a few words towards the end about rehabilitation. My view is that this should be we should avoid prolonged immobilization if at all possible. We need to rely on braces, I think, for or bracing for a short period of time.
नहीं थोड़ा ऊपर आगे है सर थोड़ा पीछे सॉरी आगे बनाएंगे थोड़ा सा थोड़ा सा और आगे हाँ यहाँ बनाएंगे
elective patients with chronic laxity where we can pick out the patient that is going to be an unreliable complier and perhaps not offer them surgery. We don't have this option with this group of patients, and it really does demand quite a lot of patient compliance to get to the ultimate goal of long-term functional stability. So what do I do? Briefly, early diagnosis is vital. I repair, and one thing we've done to get the patients early, and we've had a huge change in the timing that we get these patients. Is that we've got an acute knee clinic where we keep doctors out of the way.
तो उसको बोल दे मैं पहुंच जाऊंगा
as soon as possible.
आशु फोन कर दे मैं पहुंचूं क्या
structures within 3 weeks. I augment the mid-substance tears of the patellar tendon and posterolateral corner. I promote early mobilization, and then I carry out a planned delayed PCL and ACL reconstruction. And I try and do that relatively early.
Which वाला band है basically दोनों ACL PCL जो टूट के मिल गए ना we try not to remove that.
But these vast majority of these patients are NHS.
थोड़ा चोपड़ा का पीजी था ना सर ये
potential.
तू थोड़ा चोपड़ा का पीजी था आशु
planned elective surgery.
ओए आशु तू चोपड़ा का पीजी था तू थोड़ा चोपड़ा का पीजी था.
So in conclusion, ladies and gentlemen, I would advocate early diagnosis in these patients, and I would advocate an early repair of repairable tissues. I consider the role of planned delayed reconstruction. I think you need to set realistic goals that the patient needs
making
to
the whole light यार हदे के टाइम्स माहौल
this isn't the type of surgery
लो गाइड दो नहीं पहले प्रोब से दिखा दूं एक बार सब प्रोब दे दे पहले हिस्ट्री तो बोल दूं.
Thank you for your attention.
या मेरा ये माइक ऑन करा दो.
Thank you very much, Dr. Robert. I think Dr. Robert has to leave for 2 surgeries, so we'll leave the question answers to later.